now call our meeting to order. We do have a quorum. I will do the invocation, and then again, we will start with the agenda items. Heavenly Father, we thank you for this day. We thank you for our many blessings that you bestowed upon us. We ask you for your guidance and wisdom as we go through the agenda items. We ask your name, in your name, amen. Okay. Again, we want to welcome our new members to our board meeting, and our first agenda item that we have today would be the administration of the oath for our new members along with members that are being reappointed, which that would be Daryl Adams, Cecilia Perez, Mark Spitzer, and myself, James Mack. And Dr. Cora will be administering the oath.
Yes, so we already had the 4 board members come in today to officially cite their oath and have sign their form and have it notarized. So just for ceremonial purpose, I'm going to read the oath and then ask each of you to reply to the oath that you shall. So let me get started here. Do you solemnly swear that you will support and maintain the Constitution and laws of the United States, the Constitution and laws of North Carolina, not inconsistent therewith, that you will faithfully discharge your duties as a member of the Cabarrus County Public Health Authority Board of Commissioners, so help you God? Cecilia, will you respond?
I shall.
Daryl?
I shall.
Mark?
I shall too.
And Jay?
I shall.
Thank you all very much. We are so glad to have you as part of the board, both rejoining us and as our new members, and look forward to a really strong and productive year helping to make Cabarrus County healthier.
Okay, thank you very much. And because we have gone back to the virtual format, after each motion, I will be doing a roll call so that we will have at least a registration of who has basically agreed to the motions that we have. So again, we will be doing a roll call after each motion. So may I get a motion to adopt the agenda for the meeting?
Up the agenda as presented. This is Steve Morris.
Thank you very much. And may I get a second?
Second, this is Mark.
Thank you very much, Mark. And again, all in favor, I will read the list. Daryl Adams.
Aye.
Dr. Hagler. No, excuse me, Dr. Daly.
Aye.
Yes.
Aye.
Dr. Laura Pons.
Aye.
Steve Morris.
Mark
Spitzer.
Aye.
And James Mack. Aye. Thank you very much. Also, I need an approval for the minutes for the June 8th meeting. They were in your packet. So may I get a motion to approve the minutes for the June 8th meeting?
So moved. This is Mark.
Great. Thank you very much, Mark. And may I get a second?
I second. This is Cecilia.
Thank you very much, Cecilia. All in favor, I will read the list again. Daryl Adams.
Aye.
Dr. Kim Daylor.
Aye.
Cecilia Perez.
Aye.
Dr. Laura Pons.
Aye.
Steve Morris.
Aye.
And James Mack. Mark, you still there? Okay, we still have the motion carried. All right, we will start with our agenda items, and the first item on the agenda will be reports, and we will have Sue Yates to come up and take care of that for us.
Yes, good afternoon, board members. I'm Sue Yates. I'm the finance director here at Cabarrus Health Alliance. The first 3 reports that I will share with you this evening have to do with this beginning fiscal year. Our fiscal year ends on June 30th. So the first 3 reports have to do with the first month, which is July. The first report is a summary report that just gives you a snapshot of our different departments at a high level overview. And for the month of July, they are all green, which is excellent news. If there are any concerns, they would be yellow. If there were any issues, the dot would be red. The second report is your variance analysis report year to date. It compares where we're at July this year as to where we were July as of last year. If you look at the bottom, we are pretty much on target. There's only about a $4,000 difference between last year and July and this year. If you look up in the revenue, we are lower in the revenue section, but that's due to last year Walmart Foundation paid us a grant in July for the entire fiscal year. So last year's revenues in July were higher than anticipated due to that grant. The next report that I will take you to is a financial summary report. It gives you a look at the revenues and expenditures, where we are to date, and if you were to look at those numbers in a percentage wise. So you can see on the revenue percent on the far right hand is 3.8%, and the bottom is, oh, I'm sorry, 3.61, and the bottom is 3.64. So we are really close. And a lot of times our revenues are paid 1 month after we receive the expenditures. We also get a Medicaid cost settlement every year. We usually don't know what that is until sometime in the spring. So at the bottom, figure in what that would look like based on our budgeted amount. So it looks like we're starting off the year in a positive note. Does anyone have any questions before I go to the report about June 30th? Okay, I will move to the report on June 30th. We are still in the process of closing our books. We still have to put anything back that comes in that's a large amount right now, and we're getting ready for our audit in 2 weeks. The first far right-hand corner, you can see we were ended the year at around 90.8, and these are our actual numbers. And the bottom number, you'll see we were at 91%, so we were really close at keeping our known revenues and our known expenses. Again, at the bottom of the report is that Medicaid cost settlement. We anticipate, we budget for that this year due to so many changes. We did not get our information from the Department of Medicaid for the state of North Carolina until July 1st. So we did not go ahead and plan on spending that money, all of it last year, because we didn't know what it would be. And actually the wire and the actual cash came in on Friday. So that dollar amount that it looks like we're going to end the year in is around 2.3 million. That is the largest that we've ever ended a year. A lot of those things, I want to remind the board that last year, due to COVID and all the changes in our programs, we had lost 700,000. So that will be excellent to be able to replenish our fund balance with that, as well as some of our projects from 2021 that we're planning on completing due to the staff shortages at some of our contractors, as well as having issues at getting materials in. Those were not completed, and we cannot pay for those until the projects are completed. So we will use some of this to pay for those projects that are coming up in FY22. And I will bring some of those to you in September whenever we're a little bit more solidified and through our audit and our books are actually closed. For the newer board members, and just a refresher for the other ones, on the left-hand side, you can see what our actuals were for 2017, 2018, 2019, and 2020. So you can look to see how CHA has completed each fiscal year. Does the board have any questions about? Okay. Thank you.
Sue, I'm sorry, I had to figure out how to come off mute. So think of me as a new board member or an old one that never understood this the first time around.
Sure.
Okay, I lost you there for a second, but it's back now. So the Medicaid settlement is based on costs submitted. Could you help to explain that? It's a little confusing to me.
Yes, the Medicaid cost settlement amount is very confusing, even for those of us that are involved in it. So we send all of our expenses that are related to clinic and any administrative costs that are related to clinic to Medicaid, as well as all of our income that was received from Medicaid that had to do with, dental, all of our clinical services. They put all of that in a report. We also do our expenses, so anything that we had to purchase. There are allowable costs, there are unallowable costs, such as our lab cost or unallowable cost, and it all goes into a formula. Some of the things that made, so the Medicaid cost settlement in 2020 is 2021 is based on the prior year, 2020. So in 2020, we did not do quite as many services that were directly clinical because we were closed down, but our expenses were still really high. And since we offer Medicaid services, it goes into, it's probably 24 spreadsheets that come back to a final spreadsheet, but I'll be glad to review that with you sometime if you would like. So it kind of gets our expenses and our revenues from prior year into alignment so that we are getting fully reimbursed for offering these type of Medicaid services. The hospitals get a Medicaid cost settlement. Pretty much anyone that accepts Medicaid dollars can get the cost settlement. The formulas that the state use does differ whether you're a health department or a hospital or a private practice.
So is the way to think about this, and I don't want to derail the meeting here, it may take further explanation, but I've kept silent about this too long without understanding it to my own, and that's my fault. Is it the case, as I read this, that in effect we got 2 million, almost 2 million from Medicaid, and as a result of that, we were able to put 2.3 million into our fund balance?
Yes, that is.
As a deposit. So is the implication of that, and I'm going to ask this question, then I'm going to shut up. Is the implication of that for all of our various revenue sources and costs, we ended up making, and that's my private company thought, use of words here, did we end up making $2.3 million this year?
Yes, once the audit is done and we are finished cleaning everything up, it should not be too far off of that dollar amount. And like I said, it's based on 2020, and you can see in 2020 we lost $700,000, as well as had a lot of COVID expenses and things like that. So this will replenish fund balance and then help finish up some of the projects. And then if the board or the leadership has different things. But remember, our fund balance, we have to have certain percentages for the state stabilization as well as the general statutes. So we'll have a dollar amount that CHA has the flexibility to do something with, and we will know that amount once our financials are done this year.
May I ask a question along those lines?
Yes.
For the fund balance, what percentage are you supposed to have according to state regulations and law?
So you have to have at least 8% of your expenses. CHA request or requires 17%, but we also have a state stabilization that's a formula that goes in after the end of a fiscal year that gives a certain dollar amount around that too. And I'll bring those financial statements for the end of 2021 when they are complete.
All right, thank you.
Uh-huh. If there's no other questions, I believe I am done with the financial reports this evening.
I can talk about these slides.
We have Marcella coming up next.
Sorry, we were muted.
No, you're fine. I will briefly, so I am just back. I don't have any slides tonight. One, as you know, we were hoping to all meet in person. And so we have printed copies for all you board members of the 2020 Community Needs Assessment Report. I came to you last August and shared, I'm going to share my screen just because I'm going to show you where you can access it online. So if you, does everyone see my screen? Website.
Yes.
Okay, great. Perfect. Okay. So we do have printed copies for you all at CHA. So if you'd like to schedule a time and come by and pick it up, or I'm happy to bring it to you, either way works, but you can access a copy online on our website. You can either go to the About Us and under the Community Needs Assessment, you can see right here, there is the 2020 final report, and then there's also an appendices document. And if you want to watch a very short video with myself and Commissioner Honeycutt, she does an interview with me about that. So that is also there. And you can also look at previous reports. So one, I wanted to let you all know that the report is done and was submitted to the state. And the other thing is just give you a couple of updates on action items. So our priority needs are housing, mental health, and early childhood education and development. So to quickly let you all know, I'm going to stop sharing my screen. Just a couple of updates. One, mental health action plan is complete and those task force are meeting. They're focused on data and assessment, so ensuring that we have adequate data around our mental health needs in the community, whether it be through the school systems, from Atrium, or even our CIT trained officers. So that's crisis intervention team training with law enforcement. We also have a justice involved persons work group that's working on ensuring that when individuals are released from the jail, that they have appropriate supports, both from a mental health and substance use sides to decrease recidivism rates. And then our last one is a trauma-informed community. So continuing to move forward with addressing ACEs in our community, as well as some other things. The next work group that we have working is on housing. And so we actually had last Tuesday, and Commissioner Morris got to attend. I'm sure it was a riveting conversation, but we went through with all of our local housing partners and the municipalities, Concord and Kannapolis, as well as the commissioners at the county to discuss housing and identify next steps, discuss gaps, and what developing initiatives are happening here in Cabarrus County to support addressing affordable housing, workforce housing, and then address our homeless population in Cabarrus County. So we have been tasked with another meeting in 90 days where they want to review frameworks on looking at a housing continuum, but also Barbie Jones and Paige Castrell are convening our largest employers for a discussion on the role that employers play in housing, and really pushing them to realize that how are we going to address affordable housing as we continue to have new workforces here in Cabarrus. And then the last task force is focused on early childhood education and development. There are 4 work groups there, healthy, social emotional needs. There's also success in success in school and readiness to learn. And then the last work group that we've got there is basic needs, so housing, food access, and we're going to be monitoring data for each of those work groups. So once that action plan is done, and the county has hired an early childhood coordinator, Carla Brown, and she is helping to oversee that, and I serve as the committee chair for that county committee that they have. So I just wanted to give you all a quick update on the status of where those things are. And then hopefully we will have our scorecards live from a community perspective soon, and you all will have access to those anytime. Any questions for me?
Marcella, I don't have a question, but just wanted to comment that the work that is done on this community needs assessment is so important to certainly as a county commissioner. We pay attention to the results of that study. If you will look at the top 3 needs on that list, those are the top 3 efforts that we are trying to address. You mentioned early childhood development. Mental health is certainly another one. I mean, that in my opinion is our true link to the community and to the public, and we're not making decisions based on what I might think or some other individual. We're looking at the data that you folks provide through that process. So thank you, and all the many other people that are involved in that process, because it truly does make a difference in what we try to accomplish.
Thank you, Commissioner Morris. You all, when I got to come and present with the commissioners recently, I told Commissioner Morris he's a star student for the needs assessment process, because they really do. I mean, we are fortunate to have commissioners and city leaders and just leaders in our community that really use this tool to guide their work, and it makes the impact on our community so much more robust. So I am thankful to you all and the Board of Health as well, just on how much you all help to move this work along. It makes my job a lot more enjoyable, and it makes the partnerships better as well. All right. Well, thank you all for your time, and let me know when you would like a copy of the report, and I will make sure it gets to you.
Thank you very much, Marcella. And the next presenter would be Rocio, and I won't pronounce her last name. Sorry. Agrio, and she will be doing the volunteer presentation.
Good evening, everybody. Thank you, Mr. Mack, for introducing me. My name is Rocio Arquijo, and I'm the volunteer coordinator for CHA. I've been here since February working with our group of amazing. You see some of the statistics here. We have 700 volunteers. I've been working with all of them. And not last week, as the presentation says, but 2 weeks ago, we had a volunteer appreciation event for just those volunteers who gave 20 or more hours to our vaccine clinics. We invited about 170, and we had 70 people attend. So it was really great to just thank them and share some of the statistics. Before we go to the next slide, I'll share. So this group, in total since January through the end of July, they gave 13,000 hours, which is valued at $500,000, which is really incredible. And so I just put together some photos so that y'all could see. So whoever's controlling, if y'all can scroll through. Here we have some of the attendees. We put together some selfie frames. So we have photos of people with the star volunteer that says, I helped vaccinate Cabarrus County. We can keep going through. Yes, so they received a number of recognitions. We put together certificates and kind of depending on which group, kind of the first group got a really nice certificate. The second group who gave 40 or more hours, we included a pin that says Star Volunteer. And then the next group, we included an adorable syringe pin that says Community Immunity. And then the last group, which gave 80 hours or more, we also included a candle to help thank them. And then we had, if you'll keep going through, with some of our other attendees. We had lots of groups, it was really nice because not only were the volunteers really excited to see staff members, but they were really excited to see each other. Many of them spent many, many days, week after week. So you see here some of the certificates. Rolando is presenting them to our group with 80 or more hours. And you see in the middle with the flowers is Dr. Woolner, who gave, I don't remember exactly how many, but over 100 hours doing medical evaluation for us. And then in the top corner is Karen Knapp, who gave over 170 hours as one of our nurses. She mainly did observation at the vaccine clinics. So we're very excited to recognize them. We have some of our speakers, Dr. Pons, we have Erin, and we had a few others like Dr. Coyle and myself and Rolanda. And of course, I included some photos of those staff members who helped make it possible. It was members of leadership and also members of human resources. It was really great. Does anybody have questions or anything for me? All right.
Thank you very much.
My pleasure.
All righty. Okay, our next presenter would be Environmental Health Strategic Plan, and that would be Crystal.
Yes, good evening, everyone. My name is Crystal Swinger. I am the Director of Environmental Health, and we'll be going over your strategic plan this evening. Our plan is hearty. It has 12 different goals, so I will just give you a brief overview of each of these goals. And then if something catches your interest or if you have any questions, you can just stop and I'll dive in a little bit deeper to that. So our first category of data, we have two goals, one in goal one in goal three. So goal one, along with every other department, is our scorecard. So that is live. That is also includes the population accountability and performance accountability. So that is on our website, up and active. Our goal three, in part of this data, is to use the restaurant inspections, and we're going to use our software to run reports and see what the highest level of severity of demerits were for restaurant inspections, and then tailor an educational type of targeted information to these facilities to see if we see a difference between before we do that to after we do that, to see if we can bring down those priority demerits that are on the restaurants. So that's part one for our data. Our equity part of this has a couple different goals within equity, and it's quite layered. So the first one is going to be our communication. This is a one that I'm very excited about. They, and I say they, our food and lodging department, they went for a grant and received an FDA grant to get iPads and to get a language line app. So they'll be able to use that, and they have used that out in the field when they're doing inspections with other restaurant managers that don't speak English as their first language. And the first time we tried this was with a Turkish owner, and we were able to bring up a live video of an interpreter and be able to show them what the problem was, and he was able to speak to him in his native tongue, and it was fantastic. So not only did we rectify the situation, but we also gained a friend. So that's an important one that we have. Still under that equity goal, instead of equity and communication, we have equity and information. So this is a different program that we have, and that's with Vector, which is mosquito control. And we wanted to target those zip coded type of areas where there may be a lot of containers and a lot of exposure to our arbovirus kind of disease transmission. So our summer intern was working on that, the Vector Tip and Toss educational project. So those are our two big ones in equity. This one right here is very layered. So if you'll go back, just go down. that one. If you'll just hold right there for just a second. This has a lot to do with GIS. So that's the basis of this objective right here. Our goal is to GIS different types of housing and different types of physical features so that we can kind of create a big picture of areas where we could help with equity. For instance, when we do lead investigations into homes with children with high blood lead levels, we are going to GPS those locations and see if they are in a certain geographic concentrated area, or if we have repeat housing issues that come up, we'll be able to see that. And we would also use the GPS for the well program. So we will go down and GPS any kind of wells that are in the slate belt, which is near kind of the Midland area, because when water erodes slate, it turns into arsenic. So be able to document those. And also you'll see on here dental and oral health information. So Betty thought a good idea too would be able to give that information over to dental, and they could contact anybody that's using a well and see what if they wanted to get tested for fluoride levels in their water. So we're using the GPS and the GIS systems in order to kind of track those things visually for us. So our next category of social determinants of health, we have one in goal 3, and that's to strengthen our referral system. So what we have is any kind of pamphlets or flyers that's in one's already been developed that has Cabarrus Health Alliance referrals and also our community partner referrals, one side in English, one side in Spanish, just giving what it is that's offered and a contact and a phone number to that. So that's something we look forward to giving out to any kind of managers at restaurants or hotels that they can put up in their break room and share with their staff. The goal 4 for social determinants of health is the training in the NC Care 360. That hasn't begun at all, but that's something that will help us in all of these aspects in being able to really utilize that and make those connections. So all the way down to the last part of the agency, having the excellence, we have I'm excited about these two here. Goal 2 is, there's 3 ones under goal 2. So maintaining a quality program and advancing that to the next level. So all of our inspectors are North Carolina authorized. And what we would like to do is get 2 of our food and lodging staff to be FDA standardized, which is a national standard that FDA trains for and tests for, and is just an upper level tier of work kind of professionalism. So we're looking forward to trying to get 2 of those people authorized into that standardization category, and that kind of opens us up for more grants and mentorships as well. Instead of being the mentoree, we'll be able to mentor other counties. Another part of goal 2 is increase accessibility of inspections. Right now, we do have a means for anyone in the public to access. All of our inspections are online, so not just restaurants, but childcare centers, nursing homes, hotels, swimming pools. All of those are available and can be searched at any time, but it's not very well available as far as we don't promote that in any sort of way, and I'd like to change that, because that would let all of the places that we inspect know that anybody can look at their inspection at any time, and also that's a good thing for them to be also proud of as well. It's like, look, we've had 5 years and we've been 98 and above, or whatever they may have. So looking to really kind of push that to the forefront of things. The other one in goal 2 is very ambitious. So this is our project to digitize all of our septic files. We have files on paper cards from a couple from the 70s, but mainly it starts in 1982. And they're all housed in paper files in our 15 filing cabinets in our office. So we would like to start the process of digitizing those. There's a lot that goes into that. Right now, currently, we have paper and electronic at the same time. So it's kind of a dual kind of thing. So we'd like to kind of shift over into that digital part when that time comes. And our last goal 5, agency of excellence, is the staff development and succession planning. So this starts with us being fully staffed, which as of last Monday we are. So I'm so excited about that. But also really just advancing environmental health as a career. So I have reached out to several of the colleges and universities and see if we can kind of let them know what environmental health does. And for those graduates that are coming out, perhaps they'll be interested in applying for environmental health in any of the counties. And also on a local level, I'd like to get into those high schools and just kind of give an overview of what environmental health does. And at worst, if they don't like the career, they'll at least know exactly what environmental health does and the impacts that it has for the community. So those are all of our ambitious goals for the next few years. Was there any questions or anything that kind of piqued anybody's interest?
This is Daryl Adams. Whenever you want to get into the schools, let me know. We will set it up for you. Also, just kind of give you an idea that we're having a career fair on April 5th, countywide. So you might want us to plug into that as well. You will have access to close to probably about 700 students. You want to learn about environmental services.
That would be fantastic.
Any other questions for Crystal? Okay, thank you very much, Crystal. And if not, we'll move on to our next agenda item, which would be Barbara Shepherd with the School Health Strategic Plan.
Hi.
Is Barbara?
Sorry, this is Kim Reagan, and I'm actually going to be stepping in. Barb's is feeling a little under the weather, so our administrative team will be sharing our strategic plan, and so I'm going to get the ball rolling with our strategic priority 1, using data to improve health. We'll be focusing on goals 1, 2, and 3. Next slide. First goal, we too created our data platform, and our dashboard is active on the CHA website with population indicators and performance measures for the past 5 years. We've struggled in the past to be able to collect accurate and timely school level data that can be disaggregated to help guide our program so that we can continue to grow, change, and evolve as the needs of our community continue to change. But we're really excited that we have secured funding this year, which will allow us to implement a comprehensive school-based electronic medical record that's going to allow us to do just that. And so it's going to be a huge undertaking this year between getting it up and running and getting the staff trained. Next slide.
Hopefully you guys can hear me. Good evening. So as we use data to improve health, our goal is to use an equity lens for data collection, analysis, use, and dissemination. Our main objective is to assess social determinants of health and focus on disparities. We want to understand the social and emotional supports to be implemented along with current work in school health for a more strategic approach to preventative health of youth in the community, and the deadline is December 2022. So some of our action steps include examples such as identifying surveys to collect data, developing focus groups that address disparities in social determinants of health, soliciting grant funding to support new initiatives. For example, some of the preliminary work that we've done pertains to understanding how experiencing ACEs leads to toxic stress among youth in the community. As we implement these action steps listed, we can collect data through assessments and ensure interventions match community realities in each school. In addition, we want to use these assessments to identify commonalities with a focus on system level work that applies processes that are intentional and inclusive to improve school health initiatives. So that's the goal 2. scroll down to the next slide. The goal here is to implement the strategic decisions that promote data integration, sharing, and analysis to improve the health of what we call now at-promise youth instead of at-risk youth, and engage community partners. The objective is to examine the process of managing community providers to establish a framework for re-entry and the continuity of care for youth who are discharged from juvenile justice residential facilities with a deadline of December 2022. Some of the action steps include developing a release for a care process that includes enrollment with community services, secured medical and psychiatric appointments and community providers, and ensuring medical coverage prior to discharge. We also want to include current schedules that report an overview of juvenile youth populations here at a residential facility relative to data that shows demographics, chronic illnesses, and medications. And these outcomes will represent data that can be used to improve ways we engage community partners to support better health outcomes for youth who re-enter the community.
For strategic priority 3, we're going to look at goals 3 and 4. Could you go to the next slide, please? Goal 3, we're going to begin to implement the use of NC Care 360 with our school nurses. We understand the importance of utilizing resources that are within an excellent platform to allow for that. Next slide, please. For goal 4, we are looking at social determinants of health. We have created a social determinants of health screening tool that has been presented to Kannapolis City Schools. It's currently under review by their attorney. Our hope is that that will be completed and will go out at a systems level for the beginning of the school year. So every family would receive a copy of that and then would have the option of returning that form to the school nurse. When the school nurse receives that determinants of health screening tool, they can then look at it, and working with the social workers and the school counselors can connect families to resources within the community. We can also use this to guide activities and interventions that we're employing at a school health level. So not just helping individual families and students, but actually looking at the entire school community. What are the needs and how can we address those as a school health program? Next slide, please.
So for strategic priority 4, school health is going to focus on goals 1, 2, and 5. Next slide, please. So for the first goal, our objective is to incorporate Public Health 3.0 into the daily practices of our school health program by June of 2022. And we're going to accomplish this through ongoing staff education to help empower every nurse to visualize, realize, and become public health leaders in their own practice. We'll select strategies based on the assessment and community realities and leverage our partnerships with the school system to provide assistance for health promotion interventions that can be inclusive for the entire school community. And we had a summer intern this year, a Master's of Public Health student from UNC Greensboro, Kristen Stepp, who developed a preventative health strategies toolkit to help staff manage stress and improve personal well-being and health. Next slide, please.
Good evening, board. I'm Wendy Harsh. I'm part of the school health admin team, and I'm talking to you about this goal of maintaining a culture of quality improvement to advance our departmental performance. By September 2022, we'll create a structured QI plan that focuses on continual improvement of processes and our performance in the school health department that align with the strategic priorities of our agency. This goal is program and practice focused and quality improvements. It will support our staff engagement by creating a school health quality improvement focus group of nurses. This will encourage leadership and enhance practice knowledge of our team and on how to turn that curve. Our team of quality improvement focused school nurses will work with the agency team to survey our work environment and practices and identify areas that need to be improved and that will align with social determinants of health and our community assessments. One example that I want to share with you, give you a picture of how this will work, is our interprofessional collaboration within our school setting. Our nurses are a very important part of the student services management team, and they are involved in these teams at a school level. It is made up of the counselors, psychologists, principals, and lead teachers, and whoever else needs to attend these meetings. And this team will work to provide services to students who need support in being successful in school. Historically, the trends of our nurse participation in these groups has been varied and for various reasons. Using our QI focus, we can apply numbers to these reasons and find a cause. One of the reasons we believe is there is a lack of knowledge of the role of the school nurse and the support team. So with the QI focus and the work groups, they will work to establish possible gaps and causes of this, provide a improvement plan or work plan to close these gaps, and obtain measurable outcomes with post surveys in order to turn the curve. They can provide metrics and measures, and they will be formally reviewed as noted on the slide and adjusted as needed. Efforts and success will be shared among our agency, among our school health team, with partners, committee groups, and our community partners. Our work in creating a culture of quality improvement and performance will positively impact the students we serve and measured by meaningful positive health and academic outcomes for our students. Does anybody have any questions?
Can we go to the last slide, please? So within the strategic priority, we're also going to look at goal 5. We recognize the importance of impacting our community, and one of the ways we can do that is by ensuring that we have a strong team and that we are continually improving the knowledge and skills of that team. We've already made a significant amount of progress towards this goal as we have reinvented our new school nurse orientation. We've applied adult learning principles and more evidence-based practice. We listened to feedback from previous nurses and really tried to get more hands-on activities, more opportunities for them to get into their schools earlier, just to have that experience of what it means to be in a health office. We'll continue to review feedback from survey results and then just continue to enhance this orientation process based on that feedback. Another part of this is to work with HR and their new learning platform to have continuing education opportunities for our nurses and for agency nurses or for other nurses within our agency, with a hope that eventually we will actually be able to extend that into our community so that we're improving knowledge not only for our nurses at CHA, but for other public health nurses or nurses within any specialty field. We've been fortunate to be able to provide paid opportunities for our nurses to attend professional development, and we are thankful for that and feel like that will be an excellent opportunity for them to improve their knowledge, but then to bring that back to the entire team. Does anyone have any questions for any of the school health admin team?
Thanks. I want to just acknowledge both Crystal for the environmental health strategic plan and then the school health team for their planning. As just a reminder to all of you, these are the last 2 strategic plans for all of our program areas that we were bringing to you over the past year. So I'm really proud of the staff and the amount of time they put into making sure that we are starting to align all our programs with our overall agency goals. And I think we're really making great progress. And then this coming year, we'll look at starting to come back to you with some of the data that shows that we're starting to make a difference in both our programs, and then hopefully in another year or 2, we'll start to see some of those population health indicators move too as a result.
Good. Okay.
Thank you very much for that presentation. And our next agenda item would be the COVID-19 update focused on the Delta variant.
We would like to bump that and combine the update with the COVID-19 and flu vaccine policy discussion in the business agenda. That'll just help us sort of present all the data first and then talk about the vaccine policy. So we'll just make that one minor adjustment to the agenda, and I will go on to the director's report.
That'd be good.
I am going to be very brief in my comments, highlighting only one or two things across some of the program areas in an effort to stay concise so that we do have the time that we will need for both the COVID-19 presentation and the flu vaccine policy, and then for moving into closed session. So just want to highlight a couple of things. In Human Resources, Dr. Cathcart has really been doing a wonderful job of bringing some metrics to our programs. You'll see in the report that they've been implementing a new hiring process and have reduced our time to fill positions from 100 days to 42 days, which I think is really something to celebrate. We have finished the salary study and have completed the first phase one of starting to adjust the salaries of the folks who have had some of the lower salaries in the agency, and are now moving on to phase two to start to look at some additional salary adjustments we may need to do in order to establish stronger equity across the agency. For finance and grants, we submitted a large grant for $900,000 for an MAT program. We're hoping that we can secure that to help with our substance using populations. I'm going to skip right over to dental, where I've been mentioning the past year that we have been short-staffed, and we are at the point where we have just brought on a couple of positions and we are essentially full staff. So we're very excited about that. Another interesting thing that has happened is that Senate Bill 146 was voted into, was approved, which will allow for additional flexibility for hygienists to work without a dentist right on site with the hygienist. So that is really going to increase our capacity to provide more service out in the community, especially with our school health program. We're very excited about that. And will also allow us to potentially do what is another very exciting project, where we put a hygienist in our prenatal care clinic here in Women's Health to help improve the hygiene of that population, which then markedly improves pregnancy outcomes. So we're really looking for these innovative ways to collaborate and improve the health of our communities. The school health team has been incredibly busy this summer getting positions recruited for. We are also now fully staffed in school health, which has been a long time getting there. So again, thanks to the team, thanks to Steve and HR folks for making that a reality. And as you heard tonight, they're making some exciting progress on putting NC Care 360 into place so that we are doing a good job of assessing social determinants of health. We also learned that we did indeed get awarded a $1.6 million grant, that's over 3 years, to expand our trail program that had been put on hold. And that will help us really as we're attempting to have our school health program be more preventive focused and more population health focused. It will also have a big focus on equity, which really aligns with our priority areas. You're going to hear about COVID when Aaron and I talk to you about that. We are interviewing for the Cabarrus Public Health Interest position. In Healthy Living, we were excited to learn that we received, we're funded for a work site wellness PHAP student. PHAP is the program with the CDC where new graduates are placed in public health entities across the country to help them with some of their priority issues. So we've wanted to improve our worksite wellness program and expand it. So getting that position is going to help us with that effort. Environmental health, as you heard from Crystal, is also fully staffed. You'll hear a theme here that we've worked hard to get our programs all staffed, and we are excited about that. With Healthy Cabarrus, Marcella and team are very actively working now with developing action plans for our 3 priority areas, and the team has been very busy with that, and we appreciate all their efforts there. Just very quick Board of Health activities. We did have the governor's visit here in July. Mr. Mack joined us for that, and he came to see one of our vaccine clinics and was very impressed with our processes, and then held a press conference shortly after that. Commissioner Morris was also present at that, and then several of our board members joined us for our volunteer appreciation event that Rocio was telling you all about, and I really want to congratulate and thank Rocio for her efforts. I think volunteer programs are going to be such an excellent tool for us here at CHA to expand our programs and have a bigger impact in the community. And having gotten over 700 volunteers actively involved with the COVID process is a phenomenal start at making some great progress. And under this national, state, and local updates, you'll see that we've been actively addressing policy-related issues and meeting with some of our representatives and senators to advocate for policies that really will strengthen public health and or provide them information so that they can make better informed decisions about what policies to support based on that helping public health. So I know that was pretty brief, but again, I do want to make sure that we have enough time for the other items on our agenda. So if anybody has any questions, I'd be glad to answer them. All right.
Okay. With that being the case, then we will move to item E, which would be the consent agenda, and that would be Sue.
There are 14 budget revisions for you to review and hopefully approve this evening. The first 5 are just moving within line items of the same project. The next 2 are small dollar amounts. The budget's based on estimates when we put that together, and that's aligning those. The next is additional personnel cost and environmental health. They were one of the programs that were definitely affected by the salary study, as well as just their increase in their services for the community. And then the next couple that you have are the remaining are grants that we have received since the budget was put together. Again, the Elevate grant, the Trail grant, to get that programming continuing in schools, and some Office of Rural Health, as well as a positive parenting program that will align very nicely with Triple P to continue to expand those efforts. Are there any questions about the budget revisions?
Okay, if no questions, may I get a motion to accept the budget revisions?
So moved.
Okay, that's Chris. Thank you very much. And may I get a second?
Second. Lots of them.
Give me a name. Just, who that, Dr.
Show
Hager?
you I'm here and I'm paying attention, sort of. It's Dan.
Okay, Dr. Hager, thank you very much. We're going to all in favor. Darrell Adams?
Aye.
Chris Bowe?
Aye.
Dr. Daylor?
Aye.
Dr. Hagler?
Aye.
Celia Perez?
Aye.
Dr. Pons? Okay. Steve Morris?
Aye.
Dr. Spitzer?
Aye.
Thanks, Matt. Thank you very much. Our next item will be the finance policy.
So I bring to you tonight 4 finance policies. The majority of all of our financial policies have to come to the board for review every year. The only one with minor changes is the very last one, public health, primary care, and dental services billing policy. It was changed on the front page that patients can electronically or manually consent to allowing us to file their insurance. And then previously it only said electronically. Otherwise, they're just our policies saying that you reviewed them from 1 year to the next. Are there any questions about the finance policies?
Okay, hearing no questions, may I get a motion to accept the changes in the finance policy, please, or the updates?
Motion to accept.
Is that Dr. Pons?
Taylor.
Dr. Dale, thank you very much. May I get a second?
Mark.
Thank you very much. All in favor? I'll go down my list, hopefully for one more time. Carol Adams?
Aye.
Ms. Bowe?
Yes, sir. Aye.
Dr. Daylor?
Aye.
Dr. Hagler?
Aye.
Aye.
Cecilia Perez?
Aye.
Dr. Pons? Steve Morris? Mark Spitzer?
Aye.
James Mack? Yes. Dr. Pons, you still there? Motion is carried anyway. So let's move to our next item, which will be the. Okay, thank you. Okay, the COVID-19 update and focus on the Delta variants and also the flu policy. So we'll put those together.
Okay. We're going to start out. Aaron's going to go over some of our most recent data to show you what is happening with the COVID pandemic. And then I will review some of that data and some additional facts and information we want to share with you as we recommend a COVID-19 and flu vaccine policy for our employees.
All right, good evening, board members. It's good to be with you. So Steve, I will drive from my screen here because we had some updates since the packet went out. All right, so this slide is a little bit different than what you have in your packet. What I did is I actually went back to June the 7th, which is the last time you met. And so I wanted you to see really the longer term picture of what has happened since you were together. And so you can see here in June, as we were approaching July, we actually were starting to look and feel very good. So the things that are circled in red are really the best metrics in this 8-week period of time. So you can see in terms of new cases, we got down to 29 in 1 week. In terms of percent positive, we got down to 2%. Cabarrus residents hospitalized 3, and then active at one time 81. So we were cautiously optimistic, but at that same time, we were also understanding what our neighbors in other states were facing with the Delta variant. So we all were taking deep breaths while we could, knowing that we were likely going to experience much the same. So as you can see, as you move into late July and then into August, things have really just ballooned for us again. It's really everywhere in the news. So where we are today, this last week, we've had 555 new cases. We have had several additional deaths. Percent positive on the report here is 10.8. We have our weekly state report that just came in hot off the press not long before your board meeting began. It's actually at 12.8. Cabarrus residents hospitalized is high again, and I'll let Dr. Hagler and Dr. Pons talk about that if they'd like. Our active cases is at 922. We continue to vaccinate, and I'm going to show you the vaccination activity. So the team has not let up. We are out there. We are looking for people. And we have seen yesterday they saw and had an overwhelming response at the Performance Learning Center. So we do think the news of the contagious Delta variant is actually encouraging people to get vaccinated. So slowly but surely people are getting vaccinated. We would prefer that be at a faster clip. This just graphically shows you the number of cases or not number of cases, but the amount of cases, but it also breaks it down by age category. So you can see here, really still the largest age group being that 25 to 49 age. This is information that we look at every Thursday with our local superintendents, and we recently started sharing this on Monday mornings with our local leaders, which include our commissioners. Mr. Morris sits in on that, and our Chris Bowe and our mayors and managers. But you can see here our 5 to 17-year-olds, and then we break out our 18-year-olds so that we can paint a clearer picture, because we know some 18-year-olds are in college or out in the workforce. But you can see a very steep incline in this 5 to 17-year-old group, and so we really feel like that's important for our school leaders to know and understand, especially as they are reopening schools now. Same graph, but here we've added our 0 to 4-year-olds. And so while some of our school systems operate programs that also apply to our younger kids, this is helpful as we're seeing issues in our daycare and childcare centers.
Aaron?
Yes, sir.
On these two charts that you've just covered, the age range of 5 to 17 covers a group of folks who are 5 to 12 who cannot get vaccinated, and a separate group of 12 to 17 that can. Is it appropriate, and would it be valuable to differentiate those two, to break that group into two, so as to see the occurrence among those potentially vaccinated and not eligible?
Sure. I think that's a great thing to ask Medji. She's not on the call tonight, so I can ask Medji if the way we receive the data allows her to break it down like that. And so I just wrote that recommendation down. So what we would do is we would look at 5 to 11, and then really the 12 and up, 12 to 17, and then keep 18. So great recommendation. Thank you for that. And so we look at this just to see the testing that's taking place in Cabarrus County along with the percent positive. So when this is probably already repopulated on our website to be the 12% number. So testing remains readily available. And so we know that people are seeking out those resources. The state also provides a rolling average of the percent positive. So when Medji pulled this earlier today for us, you can see Cabarrus County in that 12%. So anything over 10 really causes us cause for concern. We'd like to be closer to that 5. Cases per 100,000 residents. As you know, Cabarrus County has roughly 216,000 residents. So you can take this 605 number and roughly double it to show in terms of the last 14 days number of residents testing positive here. So, all metrics point to really aggressive growth in cases here. So our vaccine clinic slide, again, the team was at the Performance Learning Center yesterday. They actually went at noon, so noon to 6, and they did close to 200 doses, a combination of first and second. And that's been the largest one-day vaccine clinic in terms of numbers they've given in a while, which is really good to see. We have a recurring visit with our friends at the Cabarrus County Jail, and so that is going well. And then our staff will be here at CHA on Thursday. Before I move on, I'll also share we are working with the state to host the FEMA vaccine trailer for 2 weeks in September. So we are looking for sites that they'll come and set up. It's really a turnkey operation, and so I'm working with our local leaders, put a call out to them to say, hey, if you have a property or location where you wouldn't mind this trailer coming to, let us know. And so if you also, board members, have ideas or recommendations, then let us know, and they can stay in one place for all 2 weeks, or they can do a week in one place and then another. And so, but they bring really everything they need, the vaccine, the personnel, and all of that. So I really appreciate our vaccine team being open to those sorts of ideas and resources to help those in our region get vaccinated. So in terms of vaccine tracking, we sit at 45% of the population with at least one dose. This does include, to Mr. Spitzer's point, those 0 to 11-year-olds. I'm going to show you our thermometers, which break that out. So you can see in our region where everyone else stands. Again, we're we're slicing away at it ever so slowly. I will just say, Rowan had been at the bottom of this pack for quite some time, and they've worked really hard and really quickly, and so they are at 45% too. So a shout out to our friends just north of us. In terms of the eligible population, the 12 and older, if you were to tease out those that are uneligible, we're actually over the 50% mark at 53.4%. And again, we really want to see that in those 70 and 80% numbers. So we're going to talk about the Delta variant, but what Meggie has put together for you here on the left, you can see the variants across the top. So the B117, B1351, those are the different variances of COVID. The Delta is the third column, the B1617.2. And you can see that's the majority strain of what's being sequenced in North Carolina. The chart to the right is showing our entire Health and Human Services region, which includes Alabama and Florida, Kentucky, Mississippi. So you can see those are really in the 86 percentage area. So we think in North Carolina we will follow the trend of others in our region. Every week, the data is showing us that that's very likely. It's unfortunate that I have to share with you that we are focused on outbreaks and clusters yet again. So we are working with various facilities you can see listed here, and we do have 2 clusters in our Harrisburg YMCA summer camp and then a Harrisburg child care. So outbreaks are 2 or more cases that are epidemiologically linked, and clusters are 5 confirmed cases. So staff are working hard. We have really encouraged staff to take time off because we know with the school year coming up upon us and everything really being reopened that we're going to see more of this, especially while we are in this surge, but cannot say enough great things about the team we have in place and their ability to pull together. Any questions about the data before we transition to vaccine policy? Real quick. Turn this over to Dr. Coyle, and when you are ready for me to advance, just let me know and I will go to the next slide.
Sure, thank you. So as Aaron showed you, I'll just summarize very briefly. We had reached a point over the summer where we really thought things were under control and we'd put the worst behind us, and we were making great progress. And then, as I'm sure you're all aware, just like in other parts of the country, the Delta variant reared its ugly head and was only seen in about 1% of cases back in April, May, and is now in a number of states, including North Carolina, the major cause of most cases of COVID, having climbed up to about 70, 80, and even more. Zach Moore from the state says essentially you can assume right now everything that's circulating is the Delta variant. And so what that is showing us is that and this is because it's a more infectious variant, okay? It's infecting more people per every case, and it is more virulent, so it's making people sicker, when they become infected. The vaccine is still very effective against it, with either preventing infection or at least keeping infection such that the person does not get sick if they have been fully vaccinated. The problem, though, as you saw from our statistics, is North Carolina is actually relatively low on its vaccination rate compared to many other states. The rate of vaccination for adults across our country is at 71%, yet you saw our stats that we are only right around 50% in North Carolina. That is one of the reasons you're seeing the COVID variants taking root. You still have a lot of susceptible people. And with viruses and variant strain development, in order for a virus to mutate into a variant strain, it needs susceptible hosts to infect and then mutate within. So the more individuals we get vaccinated, the less likely we are to see variant strains keep emerging and continuing to cause the COVID pandemic to surge. So that's a really important point to keep in mind as we move along to our recommendations here, that if we are going to get the pandemic under control, we have got to reach that herd immunity level, which most experts believe is going to be upwards of around 80% of your communities need to be vaccinated to prevent there from being enough susceptible individuals that the virus can keep finding people to infect and then mutate into a variant that could potentially be even more lethal and further evade the ability of the vaccine to be effective. So right now, the Delta variant is still, the vaccine is still very effective against it, but our big fear is that another variant strain could emerge and then the vaccines aren't effective anymore. And boy, then that really is going to put us back at square one. So go ahead, Aaron. And so I want to, you can advance. I wanted to just point out, I will just summarize what each of these studies and aspects here are alluding to. So this first one is really important because it deals with the issue of, are people who have been infected with COVID, is it really important for them to be vaccinated anyway? And what this study has shown, it took individuals who had COVID vaccine and then separated it into the group of those who, took individuals who had infection with COVID and then separated them into those who subsequently got vaccinated and those who did not get vaccinated. And what it found was that those who chose not to become vaccinated were twice as likely to become reinfected with COVID than folks who became fully vaccinated, even though they'd already had COVID. So this is showing that vaccines are even better at providing protection than natural immunity, that when we have COVID infection, our immunity starts to wane after several months, and then people are at risk for reinfection. I've already alluded to the vaccine. I was just looking up last night. There have been 1 billion doses of vaccine administered across the world, and about 330 million doses administered in the United States. So a lot of people have gotten vaccine, and that gives us a lot more information about both the effectiveness of the vaccine and the safety of the vaccine. And what we know is because of those many millions of folks who have been vaccinated, that the vaccines are providing substantial protection against infection with reducing the risk of infection by 91% when the messenger RNA vaccines are used for fully vaccinated folks. So, and that is again a very high percent for vaccines. So this vaccine is very effective and is very safe, as the VAERS reporting is showing that there are really a low number of adverse events being submitted to the VAERS, the vaccine adverse event reporting system. So go ahead, Aaron. And then this is another one of the largest effectiveness studies looking specifically at health workers, which public health workers are one of, in terms of is it preventing them from becoming infected. And this study showed that the vaccines are 94% effective and reduce the severity of illness in folks who might have a breakthrough infection. So vaccines work. They prevent the infection. They reduce severity when there is indeed a breakthrough. Okay. So, and this is what I've already started to make the point of, because I think this is so important as we go on to recommending that we have a required vaccine. That viruses have the ability to constantly change through mutation. The Delta variant that is currently circulating, the COVID virus itself is a large virus with a lot of genetic material. And so, as one virologist was explaining to us from the state last week, and Dr. Hagler could probably jump in here too with some additional points on that, but because it's that large, it has a lot more genetic material and it's a larger virus, it is much more adept at mutating and creating new and more dangerous variants. And so that is one of the big problems with COVID-19. It can easily mutate if it's got susceptible people that it is infecting and then reproducing. So this, and that's what's happening right now with the Delta variant. That is, it is found. So the virus has mutated to where it is the Delta variant is now a little bit more infectious, and is also creating a little bit more illness, and also seems to be better at making younger folks sick. So, you know, we were sort of comforted to know that younger folks were not really getting very sick when infected, but the Delta variant is increasing the likelihood that they will also be a little bit more sick. So bottom line, the COVID vaccine is keeping individuals who are fully vaccinated from getting sick, or if they do become infected and get sick, from being hospitalized or dying from COVID-19. Go ahead, Aaron. So I just have some of the variants up here. Show you again that some of the variants create more severe illness and death, but the main point to emphasize here is that the variants that are out there right now for COVID are all well controlled by the vaccine. So we have not yet seen the emergence of a variant that renders the vaccine ineffective, and that's how we want to keep this, by getting that herd immunity up there. So having only a 50% vaccination rate is problematic. So over the past few weeks, you have probably been seeing in the news that in North Carolina and across the country, more and more organizations and professional societies are coming out either requiring the vaccine for their own employees or recommending that employers do so. So Atrium and Novant and Wake Forest all partnered together locally, and just a week or two ago have required that their employees get the COVID vaccine. You will see other entities listed here, including Duke University, Cone Health, the Veterans Affairs, now just recently this morning, the US military have all created policy to say that their employees should be vaccinated. Mecklenburg Public Health Department has now made the vaccine required for all their workers, and the governor has extended to the state employees that he has jurisdiction over that they will be required to be vaccinated or undergo weekly testing. Our president is setting similar policy, and we are aware of several other local health departments that are also already about to approve, but we didn't want to share their names right now because they have not gone through their whole official board approval process. But I think, as you know, public health agencies should be leading the charge on this, both the governor and the president. have encouraged employers to require the vaccine for their employees because they legally can. And that as one way to really get the vaccination rate up so that we prevent the spread of continued variants that could put us back into a very, very difficult situation here. If you go to the next slide, these are many, many more national organizations than what you see listed here have come out collaboratively signing a letter saying that healthcare workers should be required to be vaccinated. We've listed the ones that are most appropriate for us as a public health agency. This is becoming the standard that healthcare workers especially should be vaccinated. And I feel strongly that public health workers, because our whole mission is to protect and improve the health of our communities, it's even more critical that we become vaccinated so that we do not inadvertently harm and infect others, and that we serve as role models and experts as we encourage the rest of our community to become vaccinated. Wanted to share with you what our current vaccination status is for our employees. As of right now, in August, we are at just about 70% of our employees being fully vaccinated, with another little over 5% who are partially vaccinated and still requiring that second shot for the Moderna or the Pfizer series. Another 1.6% who have expressed interest but are, still collecting information, evaluating the situation to decide to move forward with vaccination. And we've had about 25% who have said they do not choose to get the vaccine at this time. So what we have spent quite some time thinking about and working through leadership and talking with our medical leadership teams and some of the other entities that are already moving forward with the recommendation is we would also like to recommend to the board that the board adopt the policy that we will require COVID vaccine and flu vaccine for our employees. We have not previously required flu vaccine for our employees. That is another requirement that has essentially been standard amongst healthcare facilities for many years. And so we just think it's time that we bring that into the policy too. So we would be recommending that by October 31st of this year that our Cabarrus Health Alliance staff are required to be fully vaccinated or have an approved exemption on file. This would apply to all of our staff, even including staff who might be working remotely, interns that are coming from other from academic settings to do practicums with us. If we bring on temporary staff, our volunteers, and any contractors who might be in patient-facing services, such as we have some contract workers in some of our healthy living programs. We would we're suggesting that we allow new hires to have 30 days from the date of hire to get their first dose of vaccine if they are not already vaccinated or have an approved exemption, and then to provide that documentation. If someone has a medical reason why they cannot receive the COVID vaccine, that they would provide a medical exemption that has been signed by a physician or an advanced practitioner licensed in the state of North Carolina. And if the employee is on FMLA, they will have 2 weeks after returning to their regular duty position to receive the first dose of the vaccine. Go ahead. For staff who are not fully vaccinated, those who have an approved exemption, They will not be approved for work-related travel outside of their normal daily duties. So for conferences and that, where they could potentially take infection and spread to others, we would like to have them test every 7 days, which is another recommendation being made by both our state and national entities. And then to be required to use vacation or sick time for COVID-related absences, and to wear a mask at all times when in our facilities and or out in the community conducting CHA business, to reduce the likelihood that they would infect others in our community. Staff who are fully vaccinated, if they end up becoming infected with COVID anyway, then we would provide them 5 additional days of paid time since they have done everything in their power to protect themselves and but would still need to then isolate. For staff who are unvaccinated and do not have an approved exemption, either medical or non-medical, by November 1st, and they would meet one-on-one. All of our medical directors have agreed that they were available to help answer any questions our staff have and discuss concerns they may have. I would also be doing that. And then they would also meet with Human Resources to discuss their continued employment with us here at CHA. Just a few more comments. We would like to incorporate the requirement for COVID vaccine and flu vaccine into our overall immunization policy. So with the other required vaccines that an employee must have in order to start to work at CHA. So we would simply incorporate this right into our overall immunization policy. There will be an exemption process to include both medical exemptions and non-medical exemptions, and Human Resources is already starting to work through how we would detail this process and talk with legal to see, how we make sure we're complying with all requirements. And the leadership team has already been discussing how we will best communicate this plan to all of our employees and use multiple strategies to both educate them and explain the process that we are using so that everyone fully understands the steps that they will have to take in order to comply. So at this point, I would like to ask if there are any questions and then open up for discussion. And then depending on that discussion, see if there would be a motion to approve this. Any questions?
Bonnie, this is Mark. I think this is well thought through. I think it covers the bases. It's fair to everyone. It recognizes opportunities for people, particularly to have medical exemptions. I have just 2 thoughts that I will share with you, and one of them deals with this slide that's on the screen today, which specifies COVID flu as 2 diseases that we are vaccinated against. I strongly suggest that we include in the policy in the immunization policy for employees that it include other such diseases as raise themselves to a level of public health emergency. I can't, get the words right on this, but something that allows an easy path if there is something new that occurs that someone can't point back and say, oh, that wasn't in the policy. You can't require that of me. One thing just to offer as a suggestion. The other thing is that it may be important, even if not communicated in a policy statement, to have a set of non-medical exemptions that will be allowed and those that won't. So if my neighbor is willing to sign a note saying that I don't want to be vaccinated, that doesn't qualify. So I think the degree to which you can become specific about non-medical exemptions, whether or not that's published or not, I'll leave to Steve Cathcart and others, but at least have a list so that you are working in a consistent and equitable manner for any non-medical exemptions that come in.
Yeah, we've been talking that through, and Steve has been connecting with our legal representative to determine how we would address the non-medical exemption side of this.
So basically, when we talk about non-medical exemptions, the major exemption is going to be a sincerely held belief, and it can be religious or non-religious, but it goes under sincerely held belief. Anything else wouldn't be non-medical. I am working with our lawyers to come up with a tool, basically like a kind of like a check off tool to say we've gone through these steps, we've verified these things, we've gathered these documents in accordance with everything we need to be in accordance with in order to be able to make a decision on that. So I'm working with legal for that as well. But basically, a non-medical exemption is basically a sincerely held belief exemption.
Thanks, Mark. Are there any other comments or questions?
Yes, Dr. Coyle, Daryl Adams. I want to concur with Mark in his first point that you, by only leaving it as the flu and COVID, we kind of pigeonhole ourselves into just those two, because we don't know what may come up in a year, 2 years, 3 years, 4 years down the road. So having that statement, as he said, kind of opens you up to allow for future vaccinations instead of just being stuck to just those two.
Yeah, I'm thinking we would have to, again, probably talk with our legal representative about how you would word that so that it would.
Yeah, we would need to get
it would be allowed.
Right, we need to get some additional word. I mean, because we already have a vaccination policy.
Yeah.
We pretty much list all the things that we need to be vaccinated. So we're just adding to the current policy.
Yeah.
But I will check to see if there's some way to say, in the event of any further public health crisis, you may
future outbreaks.
Yeah. I can check with that.
Thank you, Derek.
Not necessarily a question, but I guess it is a question. As far as Crispo and Dr. Hagler, any concerns? What concerns are you running into, or are you running into concerns with the hospitals?
I think the answer is yes. There's folks who want an exception. I think we title them medical, which our legal folks are working on, I guess, the guardrails for that. The committee that's and religious, which again, the religious, exemption, which is broader than just religious, but it's also fairly wide open. I know from just preliminary information there's a fair number of requests for exemptions under that one. So it's going to be an interesting work through to see, what qualifies and what doesn't. And as of 2:30 today, when I was on a screening call about that the sort of guardrails haven't been shared yet from the corporate compliance and the Office of General Counsel. So
I was actually texting Dan while you were talking because Dan, you'll have to correct me, but I think diphtheria, that's a vaccine, right? And we require diphtheria vaccine. And so, I mean, we do have a list of other vaccines that are standard as far as health professionals, DPT, tetanus, those types of things. So I think the point's well taken that there is a broader list of vaccines that we require for you to come to work as a health professional. It's too late in the day. I've had too much video time today, and I can't really. It'd be tough for me to help wordsmith it from a legal perspective. What you need, I like the broadness of having a vaccine policy that allows you to address it. I also think that there is need for us to call out COVID in our mandate today, given the social dynamic that's occurring outside of our work environment. When people come to work and they apply, they expect to have a flu vaccine or a tetanus shot. I think so. I leave it to the team to really kick this around and find out which direction you want to go with it. From what are we hearing or seeing from our teams? The objections to this range from infertility to unfortunately male pattern baldness, right? I don't know. There's a lot of stuff out there that you can find on social media about what could happen if you take this. So it really is, it'd be difficult for us to nail down exactly what the objection is. To Dan's point, I think over 80% of our exemptions right now are religious exemptions. And again, late in the day, so sorry for offhanded comments, but I'd like to see if that many people are going to church, given that less than 50% of the population today goes to church. However, having said that, I'm going to go on mute again and just listen to the team.
I just want to say that I would love to make some kind of impassioned speech, but I mean, just being here and seeing what I'm seeing these days, it's very, very difficult. And my fear, of course, is that, and it will happen is if we don't get everybody vaccinated, the variants will keep coming and eventually outrun the vaccines. And so people, I don't understand their objections, but we're starting to see a lot of kids get this, and I just can't. It's hard enough watching old people get it, so to see children. So I just really feel like people who work for the Health Alliance should expect that they need to be vaccinated, because we need to be leading. We as the healthcare leaders and workers in our community and the face of public health need to be leading the charge and living as an example. And so, we had over $500,000 worth of volunteer work given in this county to get people vaccinated. There's a lot of passion about it, but I just really, it's disheartening to not see people get vaccinated, because we could have seen this thing gone by now if we'd gotten 70% of the population vaccinated. So I just think we need to redouble our efforts, and I really feel like that includes the employees at the Health Alliance. I'll walk them through the ICUs here if they'd like to see the results of not being vaccinated.
To Laura's point, I think Dan, you may have heard this data point today as well, but I think in January at our peak, we were averaging around 2 children per day in the hospital, and today I think we have 14. So this is penetrating our younger population much more fervently. The interesting thing is that when teammates are discouraged by the mandate, my comment is, hey, 90% of the physicians that you work with are vaccinated. So, at a certain point, look around you, and it's tough right now. I think for all of us, it's a very personal conversation and difficult to separate emotion from objectivity.
Yeah, I was going to say, you all are starting out with a higher baseline than we are, so that's a good thing. 75% is, I think, higher than any of the hospitals.
Bonnie, you are muted if you were just talking. I can't tell if you were or were not.
Okay.
Any other comments, discussion, concerns?
Okay, so do we want to proceed with the motion? So I guess the motion is that we move forward with a recommendation that all employees, all CHA employee and staff, have the vaccination, have the vaccine by, I guess, I don't know the date that you had put up there, but that they are required to get the vaccine. So may I have approval of that motion? May I get approval of that motion? May I get somebody to make the motion? Yeah, may I get somebody to make that motion?
Yeah, so I'd be happy to make the motion, and I would say that we adopt the recommended policy as presented to the board this evening.
And I second that.
Okay. And what I hear us saying is we are approving and seconding a motion that we adopt that policy, and we will get legal and whoever we need to get involved to make sure we have the proper wording, so that we can make sure that we're within the legal bounds and presenting that to the employees with the wording that we want to basically and can support at that point in time. So all in favor, I'll go down my list. Darrell Adams.
Aye.
Chris Bowe.
Aye.
Dr. Daylor.
Aye.
Dr. Hagler.
Aye.
Celia Perez.
Aye.
Dr. Laura Pons.
100% aye.
Steve Morris.
Aye.
Mark Spitzer.
I see Dr. Pons 100% and upper by 100%.
And James Mack. I also. So thank you very much. That is unanimous. Okay. Okay, that takes care of that portion. The only other two agenda items that are left would be informal public comments, and I don't think we have any of those at this point in time. I don't see any. Ryan, I don't think there's anybody from the public side. And announcements. The only other announcement that I have would be just to make sure that everyone sees that our next board meeting will be September the 14th. Other than that, I don't know if you have any information or any other announcements, Bonnie.
Did you not?
Okay. So at this point, I would like to entertain a motion that we enter into a closed session.
Motion to enter a closed section pursuant to the North Carolina General Statute 143-318.11A1 to prevent the disclosure of information that is privileged or confidential pursuant to North Carolina law.
And I second.
Okay, thank you very much, Cecilia. All in favor? I gotta go down this list. Darrell Adams.
Aye.
Dr. Hagler.
Aye.
Dr. Daylor.
Aye.
Cecilia Perez.
Aye.
Dr. Laura Pons.
Aye.
Excuse me, Steve Morris.
Aye.
Spitzer.
Aye.
James Mack. Thank you very much. We are now entering into closed session. May I have a motion to adjourn our meeting?
I make a motion to adjourn.
Okay, thank you very much, Cecilia. And may I get a second?
Second.
Thank you very much. That was Daryl. I'll read the list. All in favor, Daryl Adams, please.
Aye.
Dr. Kim Daler, please.
Aye.
Cecilia Perez, please.
Aye.
Dr. Laura Pons.
Aye.
Steve Morris. Mark Spitzer.
Aye.
James Mack. Thank you guys very much. Do apologize for the time that we kept you. Have a nice evening, and I'll get that information sent to you no later than Thursday. All right. Thank you very much.
Have a great night.
Bye-bye.